Welcome to Eye Contact. I'm Oliver Findl. We're talking with Dr. Nino Hirnschall about what young ophthalmologists need to know about biometry. Nino is from Austria, but is currently in Australia, in Sydney, doing a cornea fellowship. Welcome, Nino.
Thanks for having me.
As biometry has continued to improve, our results have improved. Actually, one of the reasons we have this improvement is also because of optical biometry. And maybe we should say that because ESCRS is currently in Vienna. That optical biometry was actually born in Vienna.
Absolutely. Yeah.
Institute of Medical Physics. But now, what are the fundamentals which young ophthalmologists need to know about biometry from your point of view?
Well, I think if we want to understand the core of optical biometry and also intraocular lens power calculation, we really have to focus on the main problem that we have nowadays. So if we assume we have a patient in front of us, we're going to do cataract surgery in 1 week time, and want to really assess which kind of lens this patient will be benefiting most from. Just like what we usually do is optical biometry. So it's very easy to assess axial eye lengths, and we definitely know that this will be very much the same after surgery. For cornea radii, it's pretty similar, so there might be small changes due to the incision, but in fact, there won't be a lot of change. But there's this one big factor that we really cannot predict, and that's the position of the lens after surgery. And that's actually, if you understand that, and that all the formulae that we have nowadays, conventional ones, like the most modern ones, basically just differ because they have a different algorithm to predict this position of the lens, then you understand a lot about optical biometry and the calculations. And we just go into details for these different formulae. Basically, what they do is all of them use regression formulae. And that's the second, I think, a key point that one should understand is just this constant is basically a factor that helps us to bring the average to zero, which means that the postoperative refraction will be on average zero, but still we have noise between patients.
So you have variability.
Yeah, absolutely, yeah. So what more modern formulae and different other algorithms that we are working on at the moment, different groups, try to do is not to optimize the mean, because that could be always set to zero, but just to reduce the noise between patients. Yeah.
So when we talk about keratometry, obviously we've always measured the anterior surface using keratometry or using topography sometimes. And now we hear that it's also important to look at the posterior surface. Why is that?
Well, actually, like when you look at the past, basically 80% of the refractive power of the cornea derives from the anterior surface. I mean, that's still the same, of course.
From air to cornea.
From air to cornea, exactly, yeah. So 85-ish%. So in the past, what we did was we estimated the power of the posterior surface of the cornea that was good enough for any monofocal lens. But now that we are more keen on using toric lenses, the posterior surface is much more important. And actually, we are quite lucky because in 85% of the patients, the posterior surface is with the rule. So there are two big different schools that we can just trust. One of them is to estimate the posterior surface of the cornea, and the other one is to measure it. And depending on which device you're going to use, you will have very different outcomes. So for the anterior surface of the cornea, the patient will have a meridian like from with the rule, against the rule. You can't really predict that. For posterior surface, 85% are within the rule. And so one option is now to estimate it, because we say, okay, almost all of patients have a with the rule astigmatism posteriorly. So there's a paper by Doug Koch, for example, Adi Abolafia, Graham Barrett, Peter Hoffman, and others that just like tell us that it's pretty good enough to estimate it for some of the patients. But if you have like very low astigmatism, let's say below 1.5 diopters on the anterior surface, then the posterior surface plays even more into account. Okay. You have to take it even more into account. And especially for these patients, I think it would be beneficial to measure it. When it comes to measuring it, it's just like we have Scheimpflug measurements on the one hand for the tomography, and then we have any kind of OCT measurement.
But Scheimpflug is always, when you look at the images, they look quite coarse. They don't look very high resolution. I mean, I guess OCT does a better job on that.
Well, there are different studies showing different things, but just like in our hands, the study we did together with Dr. Hoffman showed definitely that if you have a swept source OCT, your predictive factor for the residual astigmatism after surgery is significantly better with OCT technology compared to Scheimpflug. And even if you combine Scheimpflug with keratometry, you have not such a good outcome as if you would have been using OCT technology.
Okay. So LCT technology is the way to go, and what you're trying to do is reduce outliers, meaning patients who have have residual astigmatism after giving a toric lens. A toric lens is actually in the right position, but there is residual astigmatism.
Exactly, yeah.
And you think that's also because of the posterior surface?
I'm pretty sure, yeah. I mean, especially for those cases with low astigmatism, that's definitely one of the key factors we have to take posterior surface into account. If you have a patient with 9, 10 diopters of anterior astigmatism, then of course the posterior surface won't play such a role. Yeah.
Now we hear something else. I mean, we have these classical formulae. And on the other side, people talk about ray tracing, which is a different issue again. But then now something has popped up in the last few years, which was actually promoted by Warren Hill, talking about essentially neural networks. Can you just elaborate on that?
Sure. I mean, if you look at the history of optical biometry and intraocular lens power calculation, it was always a little bit more empirical, and then it was just shifting to more physical and empirical again, and so on. And now one of the concepts that's not really new actually is neural networking, and there's some different fields of medicine that are using that for a long time. And I remember that you published a paper about 14 years ago on neural networking.
Can't remember. Too long.
Together with Professor Preissner. And you also showed that, of course, there is a benefit of using neural network. So what does it mean to use neural network? Basically, it's purely empirical. You don't have a physical approach for that. It's just like you collect data and you assume that like the new eye you're going to be operating on will be similar as one eye that you've already measured in the past because it looks very similar, which makes sense.
Right. And if you put everything into a black box, essentially, you don't actually know what's happening. There's no algorithm you can understand.
Exactly. Absolutely. Yeah. So, and if you have, like, for the RBF Hill, you have hundreds of thousands of eyes in that, then you get better and better. So when you use it nowadays, is what happens if you have, like, I used it recently with an 80mm eye that was operated on, and then it shows you that they don't have enough data underlying like the result they would have. But as they have more and more data, they get better and better, and they will also be able to use it in these eyes. Yeah.
Okay. And what about ray tracing? So what's the difference concerning ray tracing? What does that do?
Well, ray tracing is basically pure physical. But then again, the problem with ray tracing is that we never know where the lens is going to sit afterwards. So we have a physical approach, and then we have to do some kind of empirical fitting to know where the lens is going to sit. And of course, like if you do ray tracing in a pseudophakic eye, you get very good results. Like you can also understand why the patient has the refraction he has. But just from a preoperative assessment point of view, you are getting better for the odd eyes, like patients after refractive surgery and these kind of patients with keratoconus and so on. But in fact, like the prediction of the position of the lens is still the same issue that we have in any other
So that's
formula.
Essentially the holy grail of power calculation, if you want.
Absolutely, yeah.
Okay, so do you have like what would be your like 3 tips in order for a young ophthalmologist who is doing biometry, who's doing power calculation, how he or she can get better next week?
Well, I mean, one option is, one thing that everybody should do is just to optimize the constants. That was shown like decades ago already, that if you don't just have the proper constant for your lens, for the lens you're using for this device, then your results will not as good as they could be. So always optimize the constants.
But this can also be done for you, because there are some sites like ULIP, for example,
Exactly, yeah.
international user, and there you can actually download the best optimized constant for that IOL type you're using.
It's just on a zip file. You just plug into your optical biometry device and it does everything for you. It takes like really 2 minutes. That's really easy. And then the second thing is always never trust your biometry. Always double check it. That's one thing. I mean, it's just like there was a paper like last year that showed just like why lenses had to be explanted because of refractive errors. And it nicely shows basically that the main issue was like surgeon factor. Basically like
incorrect lens.
Yeah, exactly. Yeah.
Just so it's a 23 instead of a 22.
Yeah. Absolutely, yeah. Okay. So always double check you have the right patient, the right eye is going to be operated on. And the third thing is maybe always learn from the first eye. So this one of the papers that was published by Dr. Olsen. And what he showed is nicely, if you have the first eye operated and you have a refractive error, correct for 38%, so let's say 40% of this error for the first eye, for the second eye.
So that means the patient turned out to be -1. We were aiming for 0. Yeah. He turned out -1 on the first eye. Then what will you do in the other eye?
You would go for plus 0.4 for the second eye. So now it shows that like for the second, because the error that you have from the first eye cannot be completely transferred to the second eye, because it could also be a measurement error, but usually the eyes are like twins.
Right.
And so you can correct.
So it means
40%.
you would aim for post-operative predicted refraction of plus 0.4 diopters.
Absolutely, yeah.
Okay. Good. Thank you very much.
Thanks for having me.
And for more information on this and related topics, please visit us at eurotimes.org.